Hello, everyone. Good morning. I would like to introduce myself first. My name is Kliment Anastasovski. I come from Skopje, which is the capital of my country, Macedonia. I work in a private dental office in which I'm one of the owners there, actually. Since I am a specialist in endodontics and restorative dentistry, I have limited my practice mainly to endodontic treatments and retreatments, but occasionally I do restorative work also. For today's webinar, I would like to talk to you about the key aspects in some of the steps of the root canal treatment, mainly the instrumentation phase, where we shape the root canals, and the last step of this procedure, the obturation phase, where aside from our dental knowledge and clinical experience, we are in a need of high-tech materials and equipment so that we can provide our patients with top-notch root canal procedures from which we can expect positive results when we do the recalling on our patients several months after we finish with that particular case. And so that is why we need partners like Fanta Dental Materials, which can provide us with that kind of high-tech equipment and materials that can ease and elevate our endodontic experience. So first of all, endodontology as a branch of dentistry is concerned with the study of the form, function, and health of injuries to and inflammation of the dental pulp and periodical region. So our job as an endodontist is to always try to preserve the vitality of the pulp tissue at first, but if in some cases that is not possible, to perform adequate endodontic treatment or retreatments to stop the spreading of that inflammation to the periodical region, and by that preventing of forming a periapical lesion. The endodontic procedure or the root canal treatment is a chemomechanical process, which means that we need to comply with every objective that is inside the mechanical and chemical part of this process, starting with the mechanical one. After the establishment of a proper diagnosis before starting the root canal procedure, we need to go ahead to the second step, or the 𝗧cie cavity preparation, where we must choose from some of the different 𝗧cie cavity designs there. And if we intend to be minimally invasive in that sense, or to practice the minimally invasive endodontics, then we need to follow their one and only principle, or to preserve as much tooth structure as possible while gaining the access inside the pulp chamber. After we have finished with the 𝗧cie cavity preparation, we then go to the instrumentation phase, or as Dr. 𝗧cie explained it, as a biomechanical preparation of the root canal system, where we need to accomplish every biological and mechanical objective to form and shape a root canal that can provide the solutions that we are going to be using after that to reach the apical 1/3 of the root canal as the part of the root canal system that has the most anomalies, so that in the end we will have a proper disaffection of that root canal system. After the instrumentation phase, we go to the last step, or the obturation phase, where we need to achieve a well and three-dimensionally filled root canal system. And by that, I mean not just filling the main root canal, but all the other accessory, the whole pulp canal system, including the lateral canal, anastomosis, apical deltas, and etc. Because we said before, it is a chemomechanical process, we need to use solutions such as the EDTA and sodium hypochlorite for disinfection of the root canal system, which we use for the clearing of the smear layer that attaches the root canal walls after preparation them, and also to dissolve the vital and necrotic pulp tissue. The minimally invasive endodontics actually refers to a concept that advocates the preservation on so much natural tooth structure as possible by downsizing the preparation of the excess cavity, the taper of the prepared canals, and the prepared apical size. So it actually refers to the minimally removal of dentin during all three phases of the root canal procedure. Starting with the coronal access preparation, where we need to be minimally in the removal of tooth structure during access to choose that kind of the access design that are more conservative than the other. Next is the canal flaring. We need to be careful to be minimally flaring, connecting the coronal to the apical preparation to choose the taper of our rotary system wisely and not go above 6% taper, or maybe to use 4% taper rotary files as the most ideal in the minimally invasive endodontics, and also the radicular apical preparation, where we need to have a conservative approach to the apical preparation, or to keep the apical foramen as small as practical. Regarding the access cavity preparation, there are different access cavity designs that we need to choose from them. Sorry. Sorry. Regarding the access cavity design, as we said before, there is the traditional access cavity design. There are more conservative ones, and even some of the ultra-conservative access cavity designs, such as the ninja access cavity or truss access cavity. And also there are a caries restoration-driven access cavity design. So it is up to us to choose for each and every one of our root canal cases which access cavity design we are going to be using for the access cavity preparation. But in my opinion, we need to have a more individual approach to each and every one of our root canal cases if we want to be minimally invasive. That said, we cannot only use one of these access cavity design, and if we are using one of them, only one of them, that means that we are going with the traditional access cavity design, and that way we are not being minimally invasive. Also, when talking about the minimally invasive access cavity design, in my opinion, and in some of studies, they have concluded that by using the ultra-conservative access cavity design, such as the ninja access cavity or truss access cavity design, we are following the main objective of the minimally invasive endodontics, but we are also compromising the latter stages of the root canal treatment, because if we are using such minimal access cavity designs, the risk of iatrogenic mistakes happening inside the root canals in the instrumentation phase, irrigation phase, and obturation, it is higher. So if you ask me, I am not a fan of the traditional access cavity as the ultra access cavity designs, but I always say to stay in the middle and maybe use the conservative access cavity design, where we preserve as much tooth structure as possible, but without compromising the latter stages of the root canal procedure. When we are talking about the minimally invasive endodontics, the most important part of the tooth is actually the area where the pericervical dentin is present, or the area that is roughly 4 millimeters above the crestal bone and 4 millimeters apical to the crestal bone, and its preservation increases the resistance of the tooth, and by that its longevity. So how we can preserve this precious dentin, or the pericervical dentin, that actually no man-made material can replace it after damaging it. We can start by choosing our access cavity design, first of all, to go for a more conservative one, instead of the traditional access cavity design, where we sacrifice a lot of this precious dentin. Also to be choosing our rotary system, especially the taper of our rotary system that we are going to be used to be smaller than 6% taper or 6% taper at most. Why? Because in the last years, when we were using more rigid files, more austenitic file systems, we needed a straight line access actually to the orifices of root canals, even to spread to the middle third of the root canal. But nowadays, we are using a highly flexible rotary file system that do not need this kind of straight line access in all of our root canal cases. So in that way, we can be more focused in preserving this pericervical dentin, and by that increasing the fractural resistance of the tooth, and by that its longevity. Here is a study they make on the impact of pericervical dentin or fractural resistance of endodontically treated posterior permanent teeth. It is actually a systematic review and meta-analysis, and they made this to evaluate if the preservation of pericervical dentin actually increases the fractural resistance of endodontically treated permanent posterior teeth, where they have concluded that based on the results of the study, there is evidence to support that pericervical dentin preservation offers fractural resistance to the endodontically treated posterior teeth. So the practice of conservative cavity preparation and avoiding the usage of instrument with high taper increases the fractural resistance of the tooth by retaining this pericervical dentin. And at last, what are the minimally invasive requirements that we need to keep in mind while performing our root canal procedure? First of all, the respecting of the structural integrity of the tooth, starting with the access cavity designs. As we talked before, we need to have a more individual approach to each and every one of our root canal cases. I would say to try to avoid that traditional access cavities, such as that the ultra-conservative access cavity designs, and stay in the middle using the more conservative access cavity designs to preserve as much tooth structure as possible, but in a way that we do not compromise the latter stages of the root canal procedure. After that, we need to follow the original canal anatomy using rotary files with adequate taper, meaning that we do not go above 0.6% taper, and maybe choose the 4% taper as the most adequate and maybe the more minimally invasive one. And also to be careful when using the orifice opener files, actually, where, in my opinion, we do not need to be using them. I do not use them in every root canal case that I'm doing. Maybe in the hands of the beginners, I do advise them for a smoother and easier preparation of the root canals, but in more practice hands, if I may say, you may avoid some cases on using these orifice opener files with big tapers, which can harm that precious pericervical dentin. And at last, we need to be keeping the apical foramen as small as practical, as Dr. Schilder stated in one of his mechanical objectives. Why? Because first of all, we cannot shape the apical foramen of the root canal that we are shaping. Even if we try to do so, we will end up damaging or transporting the apical foramen, and in that way, we will destroy that apical foramen, and we will have a lot of job to do when we will be performing the apical gauging of the apical constriction of the final step of the root canal treatment before the obturation phase, where we will be complicating that last step of the root canal procedure. So from the shaping of the root canal system, here are some of the goals that we need to be take care. There are the removal of vital and necrotic tissues from the main root canal. We need to be creating a sufficient space for the irrigation and medication, as I said before, especially to allow the irrigants that we're using, the EDTA and sodium hypochlorite, to reach the apical 1/3 of the root canal to make the disinfection maybe the most important part, where we are expecting a lot of pulpal complexities in that area, as such as the other 2/3 of the root canal, and also to make space for the medication where we are not using a single visit endodontics. We also need to preserve the integrity and location of the apical canal anatomy, meaning that we need to keep the apical foramen as small and as practical, and not to try and go shape the apical foramen, because you won't do that. You will end up destroying or transporting that apical foramen. We need avoidance of iatrogenic damage to the root structure as a main goal to not complicate the root canal procedure. The preservation of sound root dentin to allow long-term function of the tooth, and also the avoidance of irritation or infection of the periodicular tissue, meaning that you need to keep the shaping procedure inside the root canal and not allow the instruments to go outside the root canal system, and by that cause a massive flare-up to our patients. The instrumentation phase, actually, Dr. Schilder explained it as a biomechanical preparation, where we need to keep in mind between the two main objectives, the mechanical and biological, in a way that we shape the root canal system to be in a continuous and conical shape within areas cross-section diameter in the apical part and the widest in the coronal. The walls should taper evenly toward the apex and should be confluent with the access cavity, that will, in a way that will permit the 𝗧𝗪 to flow against the wall without impedance. We should keep the apical foramen, as we said before, as small as practical, and should shape and clean the canal without transporting the apical foramen. So those are the mechanical objectives, and the biological objectives of this step of the procedure are the confinement of instrumentation to the roots themselves to ensure that the necrotic debris are not forced beyond the foramen, and by that causing flare-ups and a lot of postoperative pain to our root canal patients. The removal of all tissues from the root canal space, and the creation of sufficient space for optimal obturation of the radicular space. So now I'm showing you the latest file system that Fanta Dental introduced to us. It is the rising file system, which by now actually has been proven to be a unique, powerful, and most effective file system that ensure us by using it we will produce a minimally invasive shaping. This file system provides us with extreme cutting efficiency, as well as maximum debris removal from apical to the coronal part of the root canal that we are shaping. One of the most interesting part about this file design is that it has a different night-eye phase, or every file inside this file system have a different night-eye phase determined by their role inside of the shaping procedure of the root canal. Also, it has a unique and specialized apical design on this file that makes the cone fit perfect at the end when we are testing the 𝗧𝗪 cone. So this is the lineup of the rising file system. We have the orifice opener file marked as RR. Then we have the R1, the glide path file, the R2, R3, and R4, which are the shaping and finishing files of this rotary system. First of all, we have the orifice opener file. It is a 10% taper file. As you can see, it has a very short working part to preserve as much of the pericervical dentin as possible. If you choose to use this, as I said before, in more experienced hands, you do not need to use this kind of files, the orifice opener files, in every case scenario, but in the beginners, I do advise on using this kind of file. As you can see, it has a blue alloy to make it flexible. After that, we have the 1303% file, which is the glide path file inside this file system. It is a gold alloy, if you can see, different from the previous one, and we use this kind of file for the negotiation and glide path management inside the instrumentation phase or in the starting point of the shaping procedure. And in my opinion, it is the most important part in the shaping procedure. Why? Because if we do a good job in the glide path management, then we can only use the later shaping files inside the rotary system, which are bigger in size from the glide path file, just to follow its path and shape the root canal without any error. After the R1, we have the R2, which is a 4% taper file. Again, it has a blue alloy. It is a very flexible file. You can even pre-bend it if you like, and it will stay in that shape. The maximum coronal diameter actually on the rising file is very minimal, only 1 millimeter, to preserve the pericervical dentin, as we talk about, and be minimally invasive as it should be. In some cases, you can finish the preparation with R2 and fit the 𝗧-𝗫 cone for this file, or go up to the next file, or the R3, which is a 34% taper, a gold alloy. It is a very flexible file with the same maximum diameter, as I said, 1 millimeter for the preservation of pericervical dentin. And here you can see the apical part of the file and the special design for making that apical plug while shaping the root canal system. And in most of our cases, we finish the preparation with this file system, with this file, sorry, the R3, or we can use the R4 in wider canals, which has a smaller apical diameter, actually a 28, but a slightly bigger taper than the previous one, or a 0.5% taper. Actually, we can be using this file, the R4, as a final file in this system in wider canals, or we can be using this file as an intermediate file, where in maybe calcified canals, when you are using the R2 file longer, and you do not need to go straight to the R3, you may use the R4 here between these two files, between R2 and R3, as an intermediate file, because it has a smaller apical diameter than the R3 file, and we will make a smoother shaping of that canal system. And after that, we'll be just using the R3 file to finish the preparation to 34% taper. That said, the rising file system actually is a control memory heat-treated wire. It has, as we said, a different night-eye phase in every instrument for maximum performance. Each and every file of this system has a different night-eye phase, determined by its role inside of the shaping of the root canal system. This file system, rising, provides us with extreme cutting efficiency that the design actually provides us with. Also, it gives us a minimally invasive shaping. As we said before, it is a 4% taper file. and it gives us a maximum debris removal while shaping from the apical to the coronal part, extruding the dentinal debris outside the root canal while shaping. It is actually a various cross-section design file. It has 3 different cross-sectional designs along its side, and it is a fixed or continuous taper file system. Also, do not forget the special design at the apical part that permits us to be creating an apical plug while we are shaping the root canal systems and reducing our time on the later stage where we are doing the apical gauging to fit the 𝗧𝗪𝗫 cone afterwards. I'm going to show you a case now. It is a first premolar, sorry. After the establishment of the working length using a 10K file and the apex locator, I'm using the rising file system. As you can see here, I'm not using the orifice opener file and go straight to the R1. Here you can see I'm doing the glide path management, and as you saw, I was also extirping the pulpal tissue from the canal system. After I finished with the buccal, I went to the palatal canal. And after finish with that file or the R1, I go to the R2 file from the rising. It is a 25.4% taper. You can see how easily it went in the buccal canal all the way to the end of the working length. And after that, I was shaping the palatal canal. As you can see here, the palatal canal or the apical part of this canal was more calcified than the buccal canal, so I needed more time than the buccal canal, and that is why after shaping the buccal canal and finishing it with the R3 34% taper file from the rising, I chose to use the R4 as I explained before as an intermediate file in the palatal canal, and as you can see here, it went right away to the working length because it has a smaller apical diameter than the R3. And after that, I finished the preparation in the palatal canal as well as in the buccal canal with the R3 rising, which is a 34% taper file. After that, I flush the canals. After preparation, I flush the canals with normal saline. And after that, I introduced the solutions, the sodium hypochlorite for disinfection of the root canals. But first, let me show you how perfectly the rising file system made the apical plug. As I said, their design at the apical part. As you can see, I do not use much time to determine the apical diameter or to do the apical gauging of the files using the hand file and the apex locator, because the rising file system actually did that for me. I was just only checking to make sure. I always recommend you to check the apical diameter using hand files attached to an apex locator to be sure before you are fitting the 𝗧𝗪𝗫 cone before the obturation. After that, I irrigated the root canals with sodium hypochlorite and activated with Actor Pro ultrasonic device, and this is the final part of this shaping procedure where you can see the 2 canals shaped very well. Here I am showing you some of the recommendations that the Fanta Dental made for the usement of the rising file system. Actually, in easy canals, straight canal, single rooted without curvature, you can choose to be using the RR, the orifice opener file, before measuring the length with a 10K file or a C file. for the working length measurement with the apex locator attached. And then you can go straight ahead with the R2 and finish the preparation with the R4 and fit the good aperture cone after that and finish your preparation. In medium canals, you may choose to use the orifice opener file. Again, I'm using this kind of file in some of my cases, not in all of my cases. After that, you can measure the working length with a hand file, 10K file. And after that, in this kind of canals, you must be using the R1 file, which is the 13.3% taper file or the glide path file in this file system, and finish the preparation with R2 or 25.4% taper. In moderate canals, after the working length was measured, you can be using the R1. It is advisable in this kind of cases to be using the R1 as the glide path management file, and then after that using in the same sequence the R2 and finish the preparation with the R3 or 34% taper file. In the hard cases, you are needed to be using the whole file system actually, starting from the orifice opener file, the RR, then measure the working length, always do irrigation between any file change. Then after the measurement of the working length, be using the R1, R2, and after that finish the preparation by your choice with the R3 or the R4, where you can be choosing this file as a finishing or as a intermediate file, as I shown you before. The co-producer of this file system, Dr. Emre Ofsay, and his colleague made a study on the role of temperature on the cyclic fatigue resistance from the rising file system, and they compare it with the 𝗓𝗍-𝗂𝗓 file system. And in the results that they got from this study, the cyclic fatigue test revealed that the rising file system exhibited significantly higher time to fracture and number of cycles to fracture values compared to the other rotary system, but there were no significant difference in these parameters at body temperature compared to room temperature. And they have concluded from this that the rising file system demonstrated superior performance in time to fracture tests, likely due to its control memory heat-treated wire, which enhance the durability and user comfort. So after we finish with the mechanical part of the this process of the root canal treatment, then we must keep in mind the chemical part also, or where we need to achieve disinfection in all third of the root canals. Meaning that with the mechanical objective, we create enough space for our solutions, the EDTA respectively and sodium hypochlorite, to reach the apical 1/3 of the root canal, where we expect the most complexities of this Pope canal system and provide adequate disinfection process inside the whole root canal system. For that purpose, we are going to be needing an irrigation needle, actually side-vented needles. This is Fanta Dental side-vented needle. They have both actually a double side-vented needle with a rubber stub that we can be using. I always use it to cut short my working length when doing the irrigation. I always cut short 4 millimeters before irrigating the root canal, and by that be using EDTA and sodium hypochlorite mostly, and always remember to be moving upward and downward the needle when you are irrigating the root canal to avoid making any iatrogenic damages. Also, to be the most careful when introducing your solutions inside the root canal, I advise you to use side-vented needles instead of open-ended needles, because in that way you will minimize the risk of extruding solutions such as the sodium hypochlorite outside the root canal system, and by that causing sodium hypochlorite damages. So be careful and always, in my opinion, use the side-vented needles as for you to be the most careful. So to use our time for irrigation as much as possible, we need to be using an irrigant activation methods. So you can be choosing some of these. In my opinion, I always use the ultrasonic for the agitation technique on the solutions, the EDTA and sodium hypochlorite in my final irrigation protocol, so that I can achieve as much of the disinfection of the root canals as possible. And I do advise you to do so after the finishing of the shaping procedure. This is the device that I am using. As I said, the ultrasonic device. It is Actor Pro from Fanta Dental. Sorry. It provides us with a small amplitude and strong power that give us a more stable, and it is less noisy during working. It has a front light actually that give us a better view inside our working field. The battery lifespan, it is very great actually. I'm using it for a lot of patients, a lot of cases before I attach it to the charger. As I said, it is a very ergonomical piece. It is wireless, but you may choose to use it with a cordless control, which is optional. In the box, it comes with six tips, actually three tips E98 and three tips EL96, which are different. The ones are more flexible than the other, that can meet all the canal situation requirements. And after the shaping procedure was done, as I said, every clinician should have its own final irrigation protocol. We are all using actually the same irrigants or solutions, the EDTA and sodium hypochlorite, but we all have a different irrigation protocol. This is mine here actually. I started with the EDTA, 16% EDTA. I introduced this solution to the root canal system by using Fanta Dental's 30 gauge side-vented needle, as I showed you before. And after I flush all the canals with this solution, I ultrasonically activate this solution for 1 minute of each canal by using the Actor Pro ultrasonic device by Fanta Dental. After finishing all of the root canals, I then flush all the canals with a normal saline, 5 millimeters per canal. And after I finish with that, I use intracanal suction unit to suction all the saline from the root canals and to introduce the sodium hypochlorite. I use most of the time 3% sodium hypochlorite, but in some cases where I need stronger solution, I use the full strength sodium hypochlorite. After I flush all the canals with this solution, I activate it using the Actor Pro inside of each canal for 30 seconds. I repeat these procedures for 3 times after I finish with the sodium hypochlorite, and after that I finish my irrigation protocol by using normal saline or 5 millimeters per canal. Regarding the 3D irrigation, actually, or cleaning the root canal system and the minimally invasive way of shaping or conducting the endodontic procedure. In this study, which is very recent, actually, from this month and this year, they investigated to compare the efficiency of the 3D cleaning protocol, meaning they used the sodium hypochlorite with the ultrasonic activation device on the smear layer and debris removal while using different access cavity design, meaning the traditional access cavity from in some of the groups and the conservative access cavity designs in other groups. And they have concluded from this study that a single standardized 3D cleaning protocol, such as the ultrasonic irrigation protocol, significantly improved debridement and irrigant penetration regardless of the access cavity design. So the conservative access cavity design combined with 3D cleaning frequently yielded the most advantageous outcomes. So given that the protocol relies on a commonly available equipment and straightforward procedures, 3D cleaning represent a pragmatic adjunct to overcome potential cleaning limitation associated with conservative access. So if you are concerned if you are disinfecting the canals as much as you can while using the conservative access cavity openings, you can be sure from this study here that you are doing a good job while preserving the two structures as much as possible on one side and disinfecting the root canal on the other side. And as the last step of this root canal procedure, it is the obturation step where we need to three-dimensionally fill all the root canal system. There are different techniques from which you need to choose. Every clinician has a different technique that they are using. I am a fan of the warm vertical compaction technique, and that is why I'm using that technique in maybe 90 or 95% of my cases. And in cases where I'm not able to do this technique, maybe inside of third lower molars where I don't have enough space to work, or very curved canals, then I'm using the hydraulic condensation using bioceramic sealer. As we all know, in the obturation step of the root canal treatment, a poor filling equals a negative outcome of this kind of procedure. So in most of the failures, the obturation of the endodontic system is incomplete, and in the voids left by the operator, the presence of infiltration of periapical exudate is punctually detected. So there are also other studies where they conferred even as high as 61% of endodontic associated with incomplete root canal obturations, or that a poor quality of root canal obturation is present in the teeth that required a retreatment. So in that way, you must choose the most appropriate technique that you are going to be using for the three-dimensionally filling of the root canal system. I am always advising you to use the warm good aperture technique. And if you wish to be filling all the root canal system, because in my opinion, only with this kind of technique, you will be able to fill all the other pulp canal system and not just the main canal system. So what are the warm vertical compaction technique requirements? First of all, we need to be sure to have a great apical tuck back that we need to measure with our hand files and later on with our master good aperture cone, and we need to choose a downpack and backfill device, measure them, pre-fit them, and use them in the obturation step of this procedure. So In the apical gauging part, before we start talking about that, first of all, we need to determine the end part of our shaping procedure, or where to end our shaping of the root canals, what should be our most apical part of the instrumentation of the root canals. It is a topic that is widely talked between authors and colleagues, and they have a different opinion to where we should end our shaping. But if you look at the literature, and from the histological point of view, we need to stop our instrumentation where the pulpal tissue ends and where the periapical tissue starts. So the only tool that we can use while doing a root canal procedure in our daily practice to measure the exact point of this the exact point where we should stop the shaping procedure is by using the apex locators. That is why at the beginning of this lecture, I talked to you that aside from our dental knowledge and clinical experience, we need to rely on our devices, such as the apex locator in this instance, to give us the exact point on where we should end this procedure, and by that provide our patient with the top-notch root canal treatment. So after we have determined that, we need, before the shaping actually begins, we use hand files with the apex locator attached to them, and measure that exact point where we should end our shaping procedure. And also, after the finishing of the shaping procedure, we are using the larger actually hand files to determine the most apical, or to determine the apical part of the preparation where we need to end the shaping process. And we use them by attaching a apex locator on them, and we need to go and see which hand file ends the stick with the most apical part, and have a great apical tuckback when we try to take out the hand file. In this case, I am going to mention again that by using the rising file system, it is very advantageous for us, because while shaping the root canals with the rising file system, we are also making a apical plug because of their unique and special apical design made only for this purpose, which will benefit us to have less time to spend less time on checking the apical part, or to be using the apical gauging technique by using hand files. It is a very great and very advantage for us. So I advise the rising file system for this purpose actually, and for all the other purposes in the shaping procedure. But also I want to say that I always advise you, after the usement of this file system, to check the apical part actually with the hand files, and the appropriate apical size of them before introducing the gutta-percha cone and finishing the and starting the obturation phase. When we are using the gutta-percha cones, we need to be checking if we have a true or false tuckback, or do we have an apical binding of that gutta-percha, or we have a mid-root or coronal binding, in which cases we may choose to use a smaller gutta-percha cone, or to reshape the root canal system. Here, for that purpose, you may be using this kind of measurement device to adapt the most apical part of the gutta-percha cone before inserting it, because all of the 𝗧𝗪 cone inside the 𝗧𝗪 box are not with the same exact apical dimensions. But if you are using the rising file system, there is another great part here that they made also a specialized 𝗧𝗪 and paper points just for the rising file system, which are the identical with the R2, R3, and R4 files, and whichever file you choose to end the shaping procedure, you just need to be using the appropriate 𝗧𝗪 cone for that file. After we done the apical gauging, we then need to choose our downpack device and our hand pluggers, which we will use to plug the 𝗧𝗪 left after the cutting with the downpack device. The hand pluggers from Fanta Dental has a different taper, a 2 or 3% taper, and different dimensions on their apical part, or different sizes that you need to be choosing. So before starting with the obturation phase, you need to choose your tip of the downpack device and hand pluggers very carefully, because you need to choose the widest. Actually, the best way to perform this kind of technique is to choose the widest hand plugger or tip of the downpack, the largest size, that goes 4 or 5 millimeters short of the working length, but without touching the canal of the the walls of the root canal. This is the most important part, because later on you need to be pressuring the 𝗧𝗪 or plugging the 𝗧𝗪 inside of the root canal, and you do not want the pluggers touching the walls and do a damage on them that way. So please choose your hand pluggers and tips carefully before starting the obturation phase, and you won't have any problems afterwards. This is the obturation system downpacked from Fanta Dental Materials. This is the 𝗧𝗍. There are some advantages on this device. It has a rotation tip that you can choose to use. Also, it has a front light for better vision inside our working part. It only takes for 2 seconds to reach 200 degrees Celsius, and also after working of 5 seconds continuously, the device automatically stop heating to avoid heating the periapical tissues and causing damages that way. It has a very long battery lifespan. I'm using it in a lot of my cases before charging it. Of course, it is a wireless device that you may be using it, but if you choose, you can be using it with cordless control. That is optional also. So after fitting the sealer and the master cone, you need to downpack all the way to 4 or 5 millimeters short of the working length, and cut the 𝗧𝗪 cone, and after that plug the apical part of the 𝗧𝗪 by using your pre-fitted hand pluggers. And after you do that, then you go with the backfilling in this obturation step, and for that purpose you will be needing a backfill device and also the same pre-fitted pluggers that you have chosen before starting the obturation. This is the 𝗧𝗍 obturation system backfill given us from Fanta Dental Materials. It is also wireless. There is no cord here. It has an adjustable temperature starting from 100 Celsius all the way to 230. Again, we have a very big battery. You can be using it for a lot of cases before charging it. which is very appropriate actually. And the most important part is that it only takes for 14 seconds to hit the 𝗧-𝗫 bars inside before you can start and using this device. I've used a lot of different devices for backfill, but I can surely say that this is the quickest one to heat up and melt the 𝗧-𝗫 before I start with the backfill procedure. You have four different tips actually with 23 gauges, 25 gauges, and different working length also 24 and 28 millimeters. After you are done with the down packing, you need to start with the back packing step while using the backfill device or the ear filler to introduce increments of a melted 𝗧-𝗫, 2 or 3 millimeters of increments, and then you use the hand pluggers to push and plug that 𝗧-𝗫 inside the root canal. After you finish all the way to the coronal third, then you only need a coronal sealing and you are all done. Here is another case I'm going to show you. It is an upper first molar. A colleague sent it to me for a root canal procedure. As you can see, the 𝗧cie cavity design is merely made by the previous dentist, and I only needed to reshape and locate all the orifices by using the ultrasonic device, an ultrasonic tip for this purpose. After that, in this case, I start my preparation with the orifice opener file, the RR, because as you can see, we have moderate curvature on the apical part of the mesial canal, so I wanted to have a better straight line access, if I may say, to the mesial canals. After I've done the shaping with the RR or the orifice opener file, then I started my glide path management with the R1, which is respectively a 13.03% taper file. I use it in all the root canals, and if you can see here, you can pre-bend the file before inserting it inside the root canals and shaping them, especially in cases like this where you have a very limited place of working. After I finish with the R1, I'm using the R2, which is the 25.4% taper file. I started with the buccal-distal canal and then went on all of the other canals. As you can see here, you can easily pre-bend the file before inserting it inside the root canals that need to be shaped. After finishing with the R2, then we go up to the R3 and finish the preparation, in this case with this file, which is the 30.04% taper. You can see how easily it goes all the way to the apical part actually of the or the end of our shaping procedure in this root canals. And after we're finished with those three canals, meaning the palatal, buccal-distal, and the mesiobuccal, then I go and inspect the pulpal floor for the second mesiobuccal canal. We all know that this canal is in this type of teeth, actually, the upper molars and especially the upper first molar, it is present in more than 90 or 95% in our cases. So be careful when you are inspecting the pulpal floor and trying to catch the ambitu as I did here with the 10K file. After I did the measurement of the mesiobuccal canal and the apex canal, the working length, I then went to the mechanical glide path using the R1, which actually easily went all the way to the end of the mesiobuccal canal. In this case, actually, it was it has a different apical foramen. It wasn't confluent with the first mesiobuccal canal, and I end the shaping of the MB2 canal with the 25.04% taper or the R2. This is the master cone X-ray, and then I started with the obturation phase. I used the appropriate gutta-percha cone for the rising file system, the R2 and R3 for the obturation phase. And this is the e-heater that I'm using for the downpack. And here is the hand plugger. You need to plug inside and press as much as you can. Don't be just slightly tapping on the gutta-percha. You need to be pushing so that you may have a three-dimensionally filled root canals after the completion of this obturation technique. After I finished with the first and second mesiobuccal canal, I went for the distal buccal, buccal distal, sorry, and the palatal. This is one of the post-op X-rays. You can see how nicely curved is the MB2 canal and also the MB1, which actually have an S shape form. And after finishing with the downpack in both of the other canals, the buccal distal and the palatal, then I use the E-filler for the backfilling action in this obturation step. Starting from the mesiobuccal canal, I pressed melted gutta-percha inside the root canals in 2 or 3 small increments, and then used pressure to plug that melted gutta-percha inside the root canals. And this is the final pick from the obturated root canals. So this is a take-home message for you that are choosing to use the minimally invasive way or of shaping or the minimally invasive concept of endodontics. First of all, you need to be utilizing advanced imaging modalities for better understanding the complexities of the root canal system. I always use 3 X-ray images, a pre-op, master cone, as you see, a post-op X-ray imaging. I rarely use the CBCT for my initial treatment, but in more of my retreatment cases, I am using the CBCT imaging for better understanding of the complexities or to find where the iatrogenic damages are made in the previous treatment to form a treatment plan before initiating the root canal retreatment and finish a better job than the previous one. You also need to be employing higher magnification and illumination for visualizing the pulpal space. You can be using a dental loops, but if you want to be using the best tool for this, you need to invest for a dental microscope, such as the one from Fanta Dental Materials. They can provide you with that also. And by that, I mean you will be not just investing in your patients, but also in you, because in that way you can only adjust yourself ergonomically enough so that you can prolong your dental career without any injuries. You need to be also using new instruments, irrigants for cleaning and shaping the canal system. I've shown you the latest file system from Fanta Dental Materials, the rising file system, which has proven itself by now as a minimally invasive rotary system at first, meaning that it possesses a file design that have a great respect for the pericervical dentin, as we talked about, for the preservation of that precious dentin. It also has a various cross-sectional design. It has 3 different cross-section along on its side, and it is a continuous or fixed taper, mainly 4% taper and only 5% taper on the R4. Which is the last file of this file system, and it gives us, as we explained before, an extreme cutting efficiency and maximum debris removal from apical to coronal. And it has also, not to forget, that special apical design on the apical part, so that while shaping the root canal, we are creating an apical block that will make for us an easier job when we are doing the apical gauging of that root canal system. Also, you need to be applying newer materials that increase the prognosis for restoring structure and retaining the natural dentition. And for a long-term endodontic treatment success, you must integrate respect for the concept of minimally invasive endodontics while fulfilling treatment's mechanical and biological objectives, well described by Dr. 𝗧𝗫-𝗹. So that is all for today. I thank you for your attention, and I will answer all of your questions in the comment area. Thank you and have a nice day.